Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me. He is aphakic in both eyes due to congenital cataracts, and he's a fairly young gentleman, and he's coming in for evaluation for a secondary IOL placement. He does have some thick Soemmering's ring, but otherwise a fairly robust and strong capsule as well as zonules. And so you're going to see my thought process and how I'm going to handle this case as far as placing a secondary lens and how I'm able to use the vitrector to trim the capsulotomy opening and then performing optic capture of a three-piece lens. So you can see this is a patient. There's quite a bit of Soemmering's ring. You can see there's a very small capsulotomy opening as well as posterior synechiae. So I'm placing a trocar. I'm indenting about 4 millimeters back using the cotton tip to steady the eye, and I'm placing the trocar needle about 2.5 to 3 millimeters away from my mark, tunneling, and then turning 90 degrees and going in. You can see the trocar is sitting slightly sideways, which means this is a nice scleral shelf, which will hopefully be a self-sealing incision. So those are my paracentesis incisions. This is intracameral lidocaine, and as I'm pushing it in, I'm trying to tease off some of the posterior synechiae. And this is some intracameral epinephrine as well. So again, I'm pushing as well as trying to tease off the posterior synechiae. It's not really coming off at all. But as I do this, you can see there's some vitreous coming out of the incision. So I quickly switch and inject some dispersive viscoelastic to tamponade the vitreous. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. And then I'm placing my 20 gauge AC maintainer, and then I'm proceeding with the anterior vitrectomy through a limbal incision, and I'm making sure I get that vitreous that's coming out of that wound right there. Again, this is a fairly young patient, and obviously some formed vitreous, and so I want to address that vitreous before doing anything else here. And then I'm going in the posterior approach, doing some more vitrectomy, and you can see I'm just accelerating here. So again, I'm trying to make the capsulotomy wider, and I'm trying to think about optic capture of a sulcus lens here. But in order to place the sulcus lens, I really need to get rid of the posterior synechiae. So this is a two-handed technique using 2 microforceps, and I'm trying to stabilize the capsular bag as well as pull off the iris tissue from the capsular bag. And you don't want to stress the zonules in the process, but that's why this two-handed technique is so important. Again, when you have this whitish capsule, it is a very strong capsule, and so you don't have to worry about tearing the capsule or radializing the tear in this manner. You see I'm switching here, going through the main incision to give myself a better angle so that I can try to separate the pupillary edge from the capsule as well. And you want to make sure that there's good separation between the iris and the capsule, 360 degrees, and not just at the edge, but also deep into the capsule or fornix here. And so I'm going to push some cohesive viscoelastic and trying to sweep around, making sure that there's no adhesions of the iris to the capsule. And so I'm going to go in 4x speed here, and you'll see this is very important, but it was quite tedious. I'm using the vitrector to essentially trim the capsulotomy opening. Again, this is a very robust ring of capsule, and thankfully there wasn't a large, thick Soemmering's ring in the sense that it was pushed up against the iris. Otherwise, it was fairly deep and posterior relative to the iris plane, and so I felt fairly comfortable and confident that placing a sulcus lens was going to be okay. And then again, I'm going to optic capture the optic through the capsulotomy opening here. Again, you might think, what if it'll tear the capsule? And that's just not the case with this. You can see the vitrector is trimming the opening pretty nicely, and I'm able to make it nice and round and circular. But again, it's quite a bit of a tedious process, and that's why I had to accelerate the footage here. So you can see I'm going now posteriorly. And then this is the lens. This is a CT Lucille lens, making sure it's seated deep, and then making sure the leading haptic comes out straight. Point the bevel towards the left, making sure the leading haptic goes into the sulcus. Rotate my hand so the optic comes out planar. And then this is the Maltzman, which is going to be used to dial the trailing haptic into the sulcus here. So I feel pretty good about it. You can see the optic is a little bit bigger than the capsulotomy opening, which is fine. I'm able to push the optic so that it's in optic capture configuration. But take a look here. On the left side, the haptic is crimped and it's actually tilted a little bit up above the iris plane here. And so clearly something's not right. I'm trying to figure out why it's not sitting in the proper position. So that, go ahead and place iris hooks, and this is a key. There's no reason to struggle. Go ahead and improve your view. And you can see I'm using a Sinskey and I'm pulling on the optic here, and look what happens. Did you see that? I'm going to go in slow motion, and essentially what I realized is the capsulotomy was not at the optic haptic junction. It was actually on the haptic, and that's why it was compressing the haptic and pushing it inward and causing it to tilt up. So once I used the Sinskey, I pulled on the optic, lifted it, and you can see that the optic capture part slid to the optic haptic junction, and the haptic just relaxed and went down nicely. So again, a little bit more vitrectomy. I'm injecting some intracameral triamcinolone, going through the trocar and doing some more vitrectomy. You can see the pupils getting bigger because there's anterior chamber infusion, but you can see the lens is perfectly planar now, and you don't see that unusual, positioning of the haptic that was there before. This is the surgical PI using the vitrector. Again, the cut rate is very low, and you can see there's aspiration is a linear control, low aspiration flow rate as well, and you're able to get a really nice round and peripheral iridectomy this way. Hydrating my incisions, pulling the trocar out, and as I massage the sclerotomy there and I'm putting a little pressure, you can see that it's sealed quite nicely. Because infusion is on, turn the infusion off, take the AC maintainer out, and then hydrate my incision. So again, this is a patient who is aphakic from congenital cataracts. I went ahead and used the vitrector to trim and open up the capsulotomy, perform limited anterior vitrectomy, placed a sulcus lens, a 3-piece lens with optic capture. You could see the capsulotomy was a little bit on the small side, and because of that, it did cause on the left side a crimping of the haptic because it was not seated properly for correct optic capture configuration. I used the Sinskey to lift the optic, and it caused then the optic capture to slide into the optic haptic junction, and the lens was very well centered. This patient did quite well. Postoperatively, the patient had 20/30 uncorrected vision. Again, before he was aphakic, couldn't see without correction, and he was really delighted with his outcome. So I hope this was helpful to you, and I thank you for your attention.